So my talk today is on two subjects actually, the use of OCT and the use of visual fields and how do we look at progression in glaucoma. So we'll first talk about OCT. This is originally a long talk, but I'm going to try and make it as brief as possible and as pertinent as possible. So what do we look for in OCT in glaucoma? Of course, we're looking at the retinal nerve fiber layer, as shown in the picture on the upper right-hand corner. You can see a quadrant type analysis or sector type analysis by clock hour. You can also look at the optic nerve, or you can look at significance maps, as is shown in the RNFL deviation map to the bottom. You can also look at the retinal ganglion cell layer. We'll talk more about it later, where the map of the ganglion cell layer can tell you progression of glaucoma. So here are some clear-cut cases of a patient with what you can see a very well-defined retinal nerve fiber layer defect on the top panel, and showing you a corresponding thinning of the retinal nerve fiber layer inferiorly. The same patient later on, you see a much broader defect in the retinal nerve fiber layer, and also you can see a concurrent increase in the decrease in the thickness of the retinal nerve fiber layer as shown on the OCT. So these are nice clear-cut cases, but there's a lot of things that go on between. So the question arises is, what change in RNFL thickness is significant? So if you look at the progression in the patient panel from 2009 to 2012, you can easily see how the inferior nerve fiber layer has thinned considerably over time. But what change is really significant? So a number of studies have suggested that about a 4 to 5 micron change that happens over time is suspicious for glaucoma. However, one must keep in mind that on a yearly basis, we lose something like 1 micron or 2 micron thickness due to an aging process. So the pearl here is, if you see small changes in OCT within 3 to 4 years, interpret it with caution. Large changes are needed really to make sure that this is a real defect. So on the other hand, you can see that in order for a new visual field or the earliest visual field defect to happen, you need to lose about 15 microns of retinal nerve fiber layer to see an earliest defect. So keeping this in mind, there is a margin of error in OCT, about 4 to 5 microns. So it really, when you're looking at individual scans, it can be hard to tell the difference from one to another. So to our rescue is what's available right now, just mainly with the Cirrus. The Zeiss machine is the guided progressive analysis. The machine gives you two parameters, both a statistical analytical tools. The first is an event-based analysis, which basically tells us what is the change from baseline. So for example, you see the picture panel on the top. It's kind of a nice way to tell you. You see that retinal nerve fiber layer defect in the lower panel on the top, which is right there. So when the color is yellow, it tells you it's a probable change, and if it's red, it determines that it's a real change. And again, if the change is outside the expected variability of what's determined by the machine and the algorithm, is defined as progression. On the other hand, trend analysis provides a change over time. It uses linear regression to determine if there's change over time. And that's determined in different quadrants. It looks at different OCTs and gives you a graph-like representation that you see in the bottom panel. So my advice is, if you see a change, try to repeat the OCT once to confirm, just like you do with visual fields, that this change is real. Now, why should we be interested in the ganglion cell layer? So the ganglion cell layer, as you all know, is multi-layered in the macular region, with about 40% of the thickness of the macular area. It comes from the retinal ganglion cells. Also, we know that majority of the ganglion cell population in the entire retina, about approximately 50%, is in the macular region. And the variation of macular ganglion cells is small. So why shouldn't we use a decrease in these number of cells as a measure of seeing progression in glaucoma? So GCC changes seem to be easier to detect. So you have different kinds of maps. Each machine, unfortunately, has its own way of assessing this. So you can have a normal GCC map, a deviation from normal map, and a significance map as produced by one of the machines. For me, these maps are most useful in patients where you have myopic eyes. We'll talk a little bit more about it. Very hyperopic eyes, or eyes with anomalous or tilted discs, where the RNFL measures can be quite abnormal. Large disc of patients who have megalopapillae, or patients with advanced glaucoma, this test ganglion cell layer thicknesses can be useful. So the Cirrus also has a GPA for RGC. It makes it color-coded, so easy to visualize change. As you see in the second panel, you see how the changes are occurring in the macular area and corresponding visual field changes. So it's a useful tool, especially in patients who have advanced glaucoma, where the RNFL thickness is bottomed out. There's only that much it can get thin. It can go to zero. So macular changes can be useful in the assessment of glaucoma. Now, a few words about red and green disease. In my clinic in Chicago, I see at least one patient a week as a referral with so-called pseudoglaucoma or red disease from artifacts that are created from glaucoma, or progression that has been labeled due to red disease. Some of these artifacts are listed here. The machine can, the centration circle can be wrong, as shown in the picture in the upper left-hand corner. The disc is large and the machine doesn't detect the edges well. Media opacities can cause spurious retinal nerve fiber layer thinning. The peripapillary atrophy and myopia creates havoc, and I'll show an example of that. And anomalous nerves and epiretinal membranes can all cause problems, and you see how this patient who actually doesn't have glaucoma was labeled as having glaucoma because of quote-unquote thinning of the nerve. Other kinds of artifacts result from eye movement. They result from blinking, from decentration. The signal strength is not poor. The eye is dry. You can give you a lower signal strength, and if the patient's head is tilted, you can have abnormal readings, and you may not have enough data about a particular patient in the database that is normalized present in these machines. So all of this can give red disease. So some of my friends who are experts at OCT and have their careers built on OCTs define myopia as red disease. And why is that? Because A, the normative database that is included in the machine does not have high myopes included in that database, so many eyes are labeled that way. And the second is because of the increased axial length, the retinal schisis that you might see in the peripapillary area may all contribute to false retinal nerve fiber layer thinning and progression. So here you see one example, how the nerve fiber layer looks terrible, and that's because of the peripapillary atrophy. The machine is unable to detect the changes, and therefore measuring progression is almost impossible under these circumstances. What about green disease? So here you have an instance where the retinal nerve fiber layer by OCT looks completely normal, but there is a consistent glaucomatous visual field defect here. And what's the problem here? Here the discs are small and crowded, and that's why the OCT is unable to detect the change. But if you look at the numerical values, which are too small to see on the screen, you'll actually see that the values, even though they are within the normal range, they have decreased in that particular area corresponding to the visual field defect. So look at raw numbers in small discs. So which is better for progression? So the RNFL shows faster rate of loss in early and moderate glaucoma, and probably is best used for progression as it's more sensitive. But in late disease, GCC is probably the way to go. So to summarize, you have many machines. Currently, it's used as a complementary test. 5-micron change is probably significant. GPA is available on only one machine. Use early disease RNFL, late disease OCT, and don't forget about artifacts. So talking about visual field changes, again, visual field changes occur after a lot of ganglion cells die. And you can look at visual field changes by clinical judgment or by statistical analysis available on your machines, especially the Humphrey Visual Field Analyzer. I'm not going to talk about the Octopus here today. So you can examine, sort of eyeball all the fields. I like to have them printed out serially, ensure absence of artifacts, look at the grayscales, and then you scan the total and pattern plots. So if you look at visual field, the progression, you will see that they don't occur in isolation. Usually it's the point that the gray becomes more dark. So there's horizontal spread or vertical spread, and each spot can get darker or deeper. So you don't see isolated changes in different areas. One pearl I'd like to leave you with is that make sure, visual field changes can be small incremental changes. So you really need to look at your first field at least once a year or twice a year to see how patients are doing, because you might ignore those small changes and be horrified to see your patients progressing without seeing the fields that were done previously. So for clinically, you look at the mean deviation, pattern standard deviation, and also focal changes detected by pattern deviation and diffused by mean deviation. And also keep in mind that visual fields do fluctuate. So pattern deviation is good, but as shown in this nice study that it may underestimate visual field loss. So you should have access to both total and pattern standard deviation analysis to make informed decisions. This kind of field is useless, where you have marked depression, so you need to use other methods, use size 5 targets, or either a 24-2 size 5 or 10-2 size 5. Progression in the size 5, 10-2 is made by counting the quad totals of the numbers that you see in the right-hand graph. Also, in patients who have paracentral scotomas, you might want to also do a 10-2 field because it magnifies that area and you can pick up progression faster. Now, you have event-based analysis and progression analysis available. Event-based, again, tests it from baseline. You need at least 2 baseline studies, and the machine tells you whether the field is progressing or not. What about trend-based analysis? It's a global analysis over time. One measure of this is the visual field index that most of your machines have. It basically, the cataract levels are not that influenced, and there is greater weightage on the central part of the field, which is most likely to affect visual function. So it's expressed as a percentage here. The trend-based analysis, the so-called Murphy's progressor, is no longer available. I'm just going to leave it here, not spend much time. So visual field progression can be assessed in different ways. We choose the right test to determine progression. Repeat to confirm, important to look at serial fields. Don't forget the first visual field. And both event and trend analysis are useful in determining progression. And trend analysis graphs are usually helpful in determining the rate of progression, which is very important, and determining and tailoring the type of treatment you'll give a particular patient. Thank you very much.